Hi, everyone. Welcome to September's Regulatory Roundup. It's going to be a little bit different this month. I'm happy to say that we have a presenter, Ashley Kaminski, and she is going to talk to us about a new program that she's developed. The acronym is SHIFT. It's Seamless Hospital Integration for Transfers. And the Home Care Alliance wants to pilot this with her and a few other agencies. And so she is going to give us some details. And then following that, I will do my typical regulatory roundup. But before I do that, Jake, our executive director, is going to introduce a new team member to the Home Care Alliance. Jake? I wonder if Jake's not on yet.
He is not on now.
Okay.
You introduce him.
So Colleen is going to introduce Kim. So I want to welcome Kim Portello. She is going to be the Associate Director for Regulatory and Clinical Affairs, part-time, to help me out. Kim has excellent experience. She has more than 30 plus years of home and hospice leadership. She was a former director of quality improvement and safety at Hebrew Senior Life. She has expertise in regulatory compliance, OASIS. Kim and I actually go way back. And she's going to support the home care members through regulatory and clinical inquiries, our affinity groups, policy tracking. And Kim and I are hoping to start some education for our members. So Kim, would you like to say hello?
Hi, yes, great. Colleen, thanks for that warm welcome. And I really look forward to assisting Colleen, and it's great to join this amazing team and really excited to get started and help our members and really come up with some innovative stuff to continue to move forward. So thank you for the welcome and look forward to working together. Thanks so much.
It's great to have you. Thank you. So now I'd like to introduce our next presentation. As I said, this is Ashley Kaminski. She has excellent experience. You can see all of her degrees and accreditations after her name. And so this presentation, we're going to talk about strengthening the hospital to home communication, reducing delays, and ensuring smoother transitions. And we've been working closely with the Mass Hospital Association. So once we pilot this program, we'd also be presenting that to them as well. So Ashley, can you say hello and introduce yourself and we'll get started?
Awesome. Yes. Good morning. Thank you so much, Colleen, for the introduction. So the project this morning, again, is titled SHIFT, Seamless Hospital Integration for Transitions. My name is Ashley Kaminski. I put my new last name. I just got married, so you might see either one. I work for Care Central VNA and Hospice. I'm a nurse practitioner and then the director of clinical practice there. So this is a project I'm very excited to work on and pilot. I have no financial interests or relationships to disclose. I would like to thank Holly Chafee, President and CEO of Care Central, who's facilitated this project and really pushed interagency collaboration and working together to improve patient outcomes, our intake team who helped me develop the tool, and then the Home Care Alliance, who I've worked very, very closely with, mostly Colleen, on this so far. So overall, the goal is improving care coordination for patients transitioning from the hospital setting to home to reduce gaps in communication, prevent readmissions, missed visits, ensure timely starts of care and services. And it is applicable to any of the patients that are in the hospital setting that are going to be transitioning home to home health or home hospice agencies. And so you might be wondering, how did I get involved in this if I'm the director of clinical practice? So I actually started at Care Central in January. And I came from, oh, I'm so sorry, I forgot to say advanced slide, and I told you I would. I'm on slide 3, thank you. So when I started in January, I came from a large academic hospital, and I was honestly not aware of the discharge process or the difficulties with it. So when I started, I realized how long it took me to review the referrals, sometimes literally hours to get the information I needed. And I thought it was just me at first, so I didn't say anything. But then when I started talking to other people in the agency, I realized this is a problem not only in our agency, but everywhere. So I'm really excited to hopefully develop a tool to help improve that. Next slide. So when looking at hospital to home health initiation timeline, these are some stats that I found on the initiation nationwide. I do have some real-time local statistics coming up in a few slides. One that stood out to me was that approximately 33.5% of home health episodes experience a delay with the first visit occurring greater than 2 days after hospital discharge. Again, these are more general, nationwide based. I have a really great study from the Home Care Alliance coming up in a couple of slides. Next slide. So the impact of delayed home health initiation. First, probably one of the biggest, if not the biggest, increased readmission risk. So when we don't have optimal discharge timing and planning due to misinformation, delays in visit starts, this leads to patients having an increased risk of being readmitted to the hospital. So patients receiving home health services within 1 day have a 27.2% readmission risk, where if you are after 7 days, it's a 38.3% readmission risk. Nearly 20% of all Medicare patients were readmitted within 30 days of discharge. That is from CMS as of 2024. And when we look at the cost to Medicare for these readmissions, it is $26 billion annually, with $17 billion considered avoidable. So really big number there that they've identified as something that we can avoid. And now we're at, how do we do that? The increased mortality risk. So mortality increases from 7.6% to 9.3% with care initiation delays. And then increased 90-day costs. So a delay in care leads to, on average, about $2,300 per 90-day total per patient. Next slide. So what is the return on investment? I did separate it into home health and hospital. Some of them overlap, but these in general were the biggest return on investments that I could find and could come up with. So increased referral acceptance and census growth. If our intake department is spending 30 minutes or so on a referral as opposed to 3 days, we're of course able to accept more referrals. We're able to grow our census, provide more care to patients, to families, improve star ratings by having those timely starts of care, aligning the discharge instructions from the hospital, with what we receive and what we're telling the families.
Let me just mute this.
Oh, no worries. And then the last one I identified was reduced referral rework and staff time. So according to Medalogix, it takes 70 minutes for intake at a home health agency to review a referral packet, which on average is 35 pages, to make the decision to admit or decline. However, when I pulled local sources at my agency, I had a wide variety of responses. One of our intake coordinators said it commonly can take days for hospitals to obtain all the information needed. And then sometimes it can take as little as 15 minutes with those close relationship community referrals. So really wide variety, but in general, the response was unanimous for the hospitals that it can take days for those referrals to get all the information needed. And there's a prediction from Home Care Home Base that intake coordinators should be able to enter 24 referrals per day, which, as everyone can imagine, is probably not possible when it takes a couple of days to get one referral back. Next slide. So the return on investment for hospitals, first is case management efficiency. So having this standardized tool decreases how much time is going to need to be spent back and forth with phone calls, faxes, with the home care agency, with the patient, trying to figure out what's missing, how we can get it to them. I'm sure many of us know when you call the hospital, if the case manager is seeing another patient, they're not going to be able to answer. We're going to have to wait for them to call back. Lots of delayed options there. Fewer 30-day readmissions, so ensuring a timely start of care is associated with a lower readmission risk. So in a large cohort study in 2022, a delayed start of care over 2 days had a 15.8% 30-day return versus 12.5% with a timely start of care. Next would be the throughput and bed day value. So each avoided readmission frees approximately 6.4 beds per day on average, according to a study from 2025. And so these days can be repurposed to higher margin cases, decrowding the emergency department. We are well aware that every day, pretty much, the emergency departments are at capacity because we're not able to bring patients up to the inpatient setting, whether it be they're waiting for a home health bed or whatnot. The bed situation continues to be a very significant problem. Next would be lower hospital readmission reduction program penalties. So targeting this can decrease penalties. And then lastly, improving patient satisfaction and value-based purchasing. So having timely post-discharge follow-up improves our HCAP scores. Next slide. So an assessment of what our current practice is. So typically hospital discharge planners or case managers will send the referral electronically through portals or fax. Sometimes there's a phone call, but typically it is through the portals. That information includes demographics, diagnosis, reason for referral, occasionally medication, DME. And then the referral replacement usually is on the day of discharge. And there's no current standardized tool or checklist for transitions. The hospitals, the different home primary care settings, everyone has a different form and a different way of what information is sent with some similar themes. Next slide. So this is from the Home Care Alliance survey in June of 2025 of home health agencies. And this really demonstrates and sums up, again, that this is a problem that we know as a group we've identified that exists. We've targeted the gaps, the necessary areas of improvement. So 100 agencies were surveyed. There was a 31% response rate. And it was identified that the time frame for receiving patient referrals, 55% of them were at the end of the day on discharge. So again, that goal is greater than 2 days beforehand. However, 55% of them were on the end of day of discharge. So one part of this tool is going to be implementing a timely referral so that we're not putting it out the end of the day on discharge or the day of discharge. And then 74% of agencies report incomplete or inaccurate clinical documentation delays or disrupts hospital to home transitions. So that's missing clinical summaries, incorrect demographic insurance information, and some barriers causing that are lack of a shared EMR, which is definitely a very big problem, gaps in communication, and then unclear patient expectations. So the question is, how do we move forward working towards a solution, knowing all of this from both nationwide data and local data from June from this survey? Next slide. So we're looking to create a quality improvement collaborative group that is going to focus on the care transition process. So it'll be a collaboration between home health, home hospice agencies, and hospitals to develop this standardized process, this standardized tool that can be adopted to improve patient outcomes. Next slide. The test tool that we're proposing in the PDSA cycle would be to pilot with 1 to 2 hospitals and 2 to 3 home health agencies. Care Central Beanie and Hospice is absolutely on board and excited to start this. So we're looking for others who would be interested. And we would be providing training materials on use of the transition tool. And again, identifying the goal being greater than 2 days before the discharge date, if possible, but definitely using this transition tool to try and improve outcomes. We'll then collect feedback from the hospitals, from the home health agencies on usability, gaps, needs that could be improved. Some measurements that will be collected are time to start of care, % of referrals using the tool, reported staff satisfaction, percent of referrals with complete and accurate information. So really subjective, objective data, seeing, objectively how it's working, and subjectively, is it working for the staff who is using it? Refining the tool as needed based on that feedback. Next slide. So this is the current proposed tool, which has been revised many, many times with myself and our intake team. I did originally have it a little bit longer, but our intake team identified that some of the information on there is already through CarePort, so we did make it a little bit shorter. So in general, they felt, and I feel, this is the basic information needed to accept or decline a referral in a timely fashion. So demographics, some medical information, some devices and contact information, what services are needed. Next slide. And the people who would be using this tool, so from start to finish, the hospital discharge planner, the case manager, so they're going to be the ones that are going to initiate the referral from the hospital. They're going to complete this form and ensure all the information is correct, and then put it into the portal or fax it, whichever way they use it. Typically for the hospital, it would be through the portal. The hospital physician or APP, and then the primary care provider will, of course, clarify the goals, prognosis, what orders, medications, what services are needed to make sure that everything is lined up, the discharge information is complete and accurate. Then we have the home health intake coordinator who's going to receive that referral. They're going to flag any information that's missing, confirm payer eligibility, all the different things needed to make our decisions from the home health side. And then the clinical liaison, which is the nurse in the hospital. So they're going to serve between the bridge between the hospital and the home health agency. They're going to confirm all the education has been provided, that all the different steps are in place for discharge as well. The home health clinical leader, so your director of nursing or nursing supervisor, is going to ensure a timely start of care. They're going to help with the visit scheduling, monitor for any delays, any missing information on the clinical end, guide staff on, I put use of tools, so if there's any input from the clinical side of things, that can be helpful as well. And then EMR and IT staff, so they're going to support our EMR integration. They're going to help make sure, no matter whether it's Cerner or Epic or whichever system, that we're able to integrate this. And then the patient and the family, who, of course, this is who it's all for, to make sure we're providing the best care. They'll make sure the information for contact is correct. That was identified as another issue as well, of having the wrong phone number, email address. So making sure with them that the information we have is correct to get in touch with them. Next slide. I did try and anticipate any barriers. Of course, there will be some, like with any project. So I did try and think ahead. I think that the biggest one will be, and I know that there are some transition tools that have been piloted before in other states, other countries. So one barrier will be variation in EMR systems. So we work with many, many hospitals who use Epic, who use Cerner, who use Meditech. And depending on which of those EMRs you have, there's different levels of what can be used in the system. So that will vary as well. There are different ways we can embed this tool through Power Form or Smart Forms into those existing systems, as long as they have that capability. So there is that capability of putting this form in. And we're going to be utilizing universal referral data, so the tool, and using CarePort, which is already something that exists for those EMRs. So I kind of listed the problems and then solutions in the lower bullet points. Another barrier might be staffing shortages and lack of resources. So the tool will hopefully be able to, again, depending on the EMR, auto-populate some of the information. I did look into, I don't work in IT, but I did look into if the EMRs would be able to auto pull. And it looks like some of them should be able to pull some of the data, so it wouldn't all be handwritten from the case managers. And then adding hard stops to make sure that we have those fields filled out, so they wouldn't be able to push it through in CarePort or however until those hard stops were completed. And then workflow disruption. So this is another thing they have to do in their very busy day. It's going to disrupt, the flow of how they do things. So we'll map the referral tool into the existing discharge navigator, as opposed to them needing to go to a different place to locate it, to pull it in. So the goal would be to put this into, in a lot of the systems, they have like admission navigators, discharge navigators, transfer navigators. So in that discharge navigator, it would be embedded in there for them to fill out, so that they would not need to take an extra step to go somewhere else. And we'll build the tool to mirror the narrative flow. So start with demographics, then go to clinical summary, then plan, and have it flow nicely for them to the best that we can. Next slide. And so these are references for my presentation. And again, we are looking for if there are a couple of agencies that are interested in piloting this. I did already brainstorm the tool, which I'm more than happy to revise with anyone who thinks that there should be something extra, something less. This was what our intake team thought would be the best form to make sure we have all the information. But we're really, really excited to pilot it, and I am so excited to work with everyone, and I appreciate the Home Care Alliance for working with me on this so far. So thank you.
Thank you, Ashley. That was a great presentation. So if agencies are interested, would you shoot me off an email? Let me know. We're going to start a quality collaborative group to work on this. And as I said, we really want to work with the Mass Hospital Association as well as with Mass Senior Care for the skilled nursing facilities. So that'd be great if folks are interested. And once I get some feedback, we'll arrange probably the first meeting in mid to late October. Thank you, Ashley. Anyone have any questions before we move on? Oh, okay. Cynthia? So for the regulatory roundup, as always, we like to talk about surveys. Quite a few agencies have been surveyed recently. Actually, one of our member agency is being surveyed today, or it started yesterday. And I just wanted to point out a few things. I know we know these, but these particular items agencies receive deficiencies for, so I just wanted to highlight them. As always, the surveyors are looking at the order frequency and the visit patterns. And from hearing from the agencies, they really seem to be focusing on it. They want to make sure what the doctor ordered, the visits are in the chart. And I know how difficult it is, especially if you have a scheduling and the patient declines and that information isn't in there. But actually quite a few agencies receive deficiencies on this particular one. As always, and since the beginning of time, home health aid supervision's problematic. It's so difficult, even with our EMRs and the alerts we have in our system. That's 14 days is still very difficult to do. So a couple of agencies again had a deficiency there. This was new, emergency preparedness. They're starting to scrutinize it. They hadn't really looked at it much at all after COVID. But the agencies that I've talked to, they're telling me that there has been an increased focus. They're looking through your emergency preparedness plan and asking questions and whatnot. This just came in to me last week. One agency was cited because they weren't compliant with their timely completion of discharge summary. So as the COPs state, it should be 5 days. So they were like 6, day 7. And unfortunately, the surveyor found more than one. They found a couple, so they had to put in a corrective action plan. I didn't ask the person, but transfer summaries, as you know, should be done 2 days of the transfer or your knowledge of the transfer. And then this is specific for Joint Commission. One of our agencies, member agencies, was surveyed last week, and the surveyor gave them a deficiency because they only have one physical therapist, and the RN was doing the annual supervisory competency on them. And as it does say in the JACO standards, it has to be discipline specific. So I actually recommended to them to try to subcontract with a neighboring home health agency, and I recommended a couple of staffing agencies. I'm not sure if they could help with that, but and if anyone has any brainstorms about who else they could get to help with that supervision, I'd appreciate it if you'd shoot me an email. Anyone have any questions about survey? Or please feel free, unmute your line if you've been surveyed or you want to chime in. Please do so. Okay, Cynthia. Next slide. So this is this just came out on August. So Department of Public Health updated their guidance for the healthcare personnel for specifically respiratory illness infections or exposure. This is effective as of September 1st. This supersedes the one from 2022, and last May of 2024, they had updated again. This has changed. So who needs to isolate? It's the healthcare personnel with a positive test or have more than 2 symptoms of a respiratory illness, cough, sore throat, etc. So the return to work policy now is that if they were symptomatic, they're allowed to return to work on day 4. So after more than 3 days since the symptom onset, and the symptoms are improving, and they have fever-free without antipyretics, and they feels well enough to work. For asymptomatic positive, they can return to work on day 4, so it's greater than 3 days. And then masking after the return to work, if back before 8 days, wear face mask through day 7, and then you would remove it on day 8. And as it says in the regulation, it actually says, so day counting, day 0 is your symptom onset or the test that was the test date. Next slide, Cynthia. This is continuing. It's the same guidance. So if you were exposed only, you had no symptoms, there was a negative test, you may continue working, but you have to wear appropriate PPE and at least a medical procedure mask and self-monitor for 5 days. There is, in that guidance as well, there's some special considerations for immunocompromised staff. And towards the end of the guidance, it's specifically talking about the expectations for your agency's infection prevention. So really looking at your policy and procedures would be part of that. So I know a lot of agencies are going to be, they're telling me they're coming up for survey. So I want to make sure everyone had this most recent guidance. Next slide, Cynthia, please. This caused a lot of talk this summer. So as we all know, OASIS for all payers is mandatory. And I guess I didn't even think about this, but there's been a lot of questions. So CMS actually had to develop a Q&A specifically for the OASIS regarding all payer. And in that, it said that if an agency, a home health agency, was going to switch to Part B benefit because the patient wasn't homebound anymore, that they still had to do the OASIS. I had so many calls. I emailed CMS myself 3 times. I didn't get a very clear answer. I actually talked with Mary Carr at the National Association. We went back and forth. And then finally, CMS did get back. I think it's a couple of weeks now. So this is great news. they did retract that OASIS requirement. So if you have PTOT and speech and you're billing Part B benefit, there's no home health plan of care in effect, then you don't have to do that OASIS. CMS will release a new Q&A. I did look recently. It's still not updated, but I'll keep my eye on it. And this is really good because this does reduce some unnecessary administrative burden. I had a meeting the other day with the therapist, and there's a lot of agencies who do outpatient Part B billing once their patient's not homebound. So there was a lot of positive feedback from our members on that. Next slide, please. I'm bringing this to your attention because I've been getting an awful lot of questions lately. So as you know, the CMS proposed rule came out in the summer. The comment period is closed, but in that proposal, this is a good thing. CMS is proposing that the face-to-face, it will be kind of less strict, I guess I could say that. Discharge paperwork could be from any facility, not the direct admit one, which would be very helpful. They're going to expand the list of the eligible encounter providers, which is huge. So I've been having agencies tell me that we can start doing this now. No, we can't. And apparently someone, a couple of our agencies listened to a recent webinar, and the speaker said that it was allowed. It is not. We will find out exactly what it will say in the final rule. The final rule is to come out at the end of October. Home Care Alliance staff really looks over that rule. So as soon as we get information out on that, and there is an effective date, I'll be sure to tell our members. But I didn't want people to be out of compliance by accident. So I'll keep you informed. The other thing I noticed about the face-to-face requirement too is the enrollment. So as of now, only the certifying provider has to be with PICOS or Mass Health enrolled. And so I was just thinking ahead of this, if this does finalize, and it's not clear now, would there be a change in the PICOS enrollment expectations for all of those other providers? So it's not clear, we don't know, but I'll definitely be clarifying that with the final rule. And if it's not clear in the final rule, I'll shoot off a letter to CMS. Next slide. CMS, again, I guess they've been busy, just sent out a recent on their MLN Matters, Medicare Learning Network. They sent out a new fact sheet. So this is CMS signature requirements. The link is here. We will be giving you the slide deck, by the way. I'm sorry I didn't get it to you in advance. And when you open this, you'll see there's a lot of this red, so you can quickly see what's different. CMS, even though this has always been a regulation, I guess maybe it wasn't in this particular document, but stamp signatures typically are not allowed. However, if the practitioner has a disability and they can't sign, they are allowed to use a stamp. However, they have to have like this proof, and you'd have to have that in your chat. I was kind of surprised, honestly, when I saw that, because I was thinking so much of this is electronic signatures, but I guess some still might have that stamp. So that was added. There was documentation when you have, there was information, excuse me, about documentation. So if you had your note was from a scribe or you did AI, it's allowed, but you do need to have the provider's signature must be clear with that documentation. And then finally, signature attestation logs. They went over that. It's kind of in a lot of detail. It is allowed. They recommend it if you can't make out the signatures. And if there was a question about a signature, you have a 20-day response if they requested it from you if you had an audit. Next slide. These are just a couple of other things. This is, let's keep our fingers crossed on this next one. Telehealth update. On Wednesday, the Republicans unveiled a continuing resolution to fund the government through November 20th, and that included an extension for telehealth for home health and hospice. Unfortunately, it needs to pass through Congress before this happens. So we're really hoping it does, but you also be prepared on the back burner that if it doesn't go through, we're going to have to notify our referral sources, providers, that face-to-face won't be able to be accepted by audio-visual if it doesn't pass, but we have our fingers crossed. PEPA reports were supposed to be out by now. They haven't been. I know I looked at these reports a lot when I was a quality director, but they're supposed to be released late fall now for both home health and hospice. So I'll keep you updated on that. Excuse me for a second. Excuse me. The Home Care Alliance staff developed an OSHA injury reporting toolkit for home-based care. There had been some changes and it is a bit confusing. So we developed the, as I said, this toolkit that is a link for our members if they want to use it. This is going to help for next year. So your 2025 injury reports and illness data that you need to submit by the March of 2026. So it's just to help you simplify and improve your compliance and your workplace safety. I did present this to the HR affinity group this week, and they were pleased with it. So, well, hopefully you don't have that many injuries, but at least you have a reference that you might be able to use. Next slide, please. So this is another update, but this is from the Office of Civil Rights and the Assistant Secretary for Technology Policy. They released a security risk assessment tool. This is version 3.6. There's the link. This is a free resource to help covered entities and business associates and to meet your HIPAA security and risk analysis requirement. And this actually, just this minute, it came to my thought a few months back. One agency actually was cited because they looked at their performance improvement, not performance improvement, excuse me, their emergency preparedness plan, and a risk assessment hadn't been done since like back in 2018 or something. So this might be helpful for agencies. This apparently is a desktop tool, but it's wizard-based workflow. I didn't even know what that was. I had to look it up, but it's ideal for small and medium-sized providers, not for the big providers. It wouldn't be as helpful. Next slide, please. So this is another area that's had a lot of action over the past month. CMS sent out sanction notices. They issued them on September 5th for agencies who had less than 30% auto verification for the fee-for-service only Mass Health. And you have 90 days to comply to get up to greater than 30%. And for agencies that don't, there will be sanctions. We have had quite a few agencies call us. They did receive these notices. Some agencies shouldn't have received the notice. They don't even have Mass Health billing. So, we've been working individually to get those straightened out. But I think some agencies are struggling with it. Mass Health has told us either the majority of agencies are up over 80%, and then there's, a whole handful that are struggling that are lower than the 20% or 30%. And then there's another checkpoint for Mass Health for your auto verification. So from the dates of July 1st through May 31st of 2026, they are expecting a 40% auto verification requirement. Okay, next slide, Cynthia, please. Also with Mass Health, this just came out recently. It's Bulletin 131. So for the senior care option enrollment, they've had some changes. So as of January 1st of 2026, the SCOs are limited to dual eligible members only. So on August 1st, the SCO plans had to stop enrolling Medicaid only patients. And then, so for the current Medicaid only patients who are in a SCO, they're going to have to transfer to fee for service in January of 2026. So I just wanted people to be aware of that. You might have a payer change with some of your patients. Next slide, please. This is just a reference. The Hospice Hope training resources. There have been a lot of educational materials provided by CMS. I've heard some really positive feedback that they're quite good. They had a live coding workshop in the beginning of August. So that recording is available now on the website, as well as all of the training material. I think there's like 5 or 6 different webinars. I haven't viewed them all yet. And then there's a frequently asked questions. And there have been a lot of questions. I'm on a national listserv. There are questions every single day about that Hope assessment. And next slide. That's it. And does anyone have any questions or feedback about anything? And if you don't want to unmute, you could always put it in the chat. I'll give it a minute, but we will have a meeting again in October. And, you know, depending upon member feedback, if our members are enjoying this regulatory roundup every month, we'll continue into 2026. So, you know, if you can send us some feedback, whether it's yay or nay, that would be good. So I don't see any questions, Cynthia. I can't see the chat, Cynthia. Any questions?
Colleen, forgive me if I missed this. Did you mention the telehealth?
I'm sorry, I didn't hear you.
Did you mention telehealth?
I did.
Oh, okay.
But why don't you know more than I do, Jake? Can you add, please?
Well, I'm sorry that I missed it. You know, depending on what Colleen said, I think that just last night, congressional Democrats unveiled their version of a government spending bill, and that version as well does include extensions for telehealth. So we now have 2 competing bills from each party in Congress to keep the government open past September 30th. I think the question now, particularly for Democrats, is whether they're going to hold strong in order to get some healthcare concessions around Obamacare premiums. And so it is possible that we do head to a government shutdown for some amount of time, in which case the telehealth extensions would lapse. So I just think the most important thing for you all is to kind of prepare for that lapse, even if it's temporary for 10 days or so, 15 days, which would impact your operations. But I do think that given that both versions have included the extensions, it's clear it's a bipartisan issue to extend these in one way or another. But we just need to get these permanently extended. But as of now, it seems like we're going to continue on this cycle of, 6-month extensions. So I just think the most important takeaway from all of that junk I just said is to be preparing for any temporary lapse.
Thank you, Jake. I was just looking at the chat, the slides. I'm sorry if I didn't say it. The slides will be sent out after this. And let's see. Oops, I just lost my chat.
There's a question about EVV. I'm not sure if it's a question or. Yeah, it's a question. It says.
Go ahead. I see it now. I see it now. Let me.
Okay.
Yeah, for EVV, the providers that fail to meet the June 30th metrics and receive the Shanks notice, is there a requirement to meet that main visit have to be provided from 1/1 to 6/30? Some do not have EVV. Some do not have EVV set up, so would not have that. Or is it just what has been sent within the 90 days, regardless of dates? Or in other words, do we have to go back and submit old notes prior to 6:30. I don't know.
Maybe.
Do you know that, Jake? Is that going back or is it just going forward for the 90 days?
Maybe.
You know, I don't know the answer to that question. But
Yeah, we should ask.
Yeah, I'm going to ask Mass Health. I'm not sure, to be honest. That's a good question. But we'll find out. And the other one, Grace told me that the staffing agencies do not perform annual evaluations for physical therapists. So thank you for telling me that. And they would appreciate any guidance from members on the call that know of an agency that would perform this for another agency to subcontract. So if someone has a physical therapist manager or a staff member and you want to subcontract with someone else, shoot me off an email and I'll be able to connect you with that agency. We are working with some providers. Okay. Yeah, definitely. I don't know the answer to that EVV. I'm sorry. I'm going to, I'll shoot off an email to Mass Health today and find out. And I'll get back. I'll have Cynthia or I'll get back to everyone with the answer I hear back. Okay. I think that's it. All right, everyone. Have a great rest of your day and have a nice weekend coming up.